SAGES Stories.
Welcome to today's episode of SAGES Stories, the official podcast of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Please make sure to hit the like button and subscribe so you can stay up to date with our most recent episode. And enjoy the show.
And we will be right back after this message from the SAGES Guidelines Committee on 2 exciting positions offered to surgical residents.
Hi, everyone, and welcome to SAGES Stories. My name is Elisa, and I'm the current SAGES RACS Research Fellow based in Adelaide, Australia. Today, I'm really excited to share a little bit about my experience and also talk about 2 different research opportunities available for surgical residents through SAGES.
And I'm Dina, one of the current SAGES Fellows. Together, we'll give you an overview of the 2 different SAGES positions since they're a little different.
So let me start with the Australia-based fellowship. This is a 2-year position jointly funded by SAGES and the Royal Australasian College of Surgeons, or RACS. It requires relocation to Adelaide, Australia, which has honestly been an amazing adventure for me. In this role, you not only work on systematic reviews and guideline development with SAGES, but you also complete a master's degree by research with RACS. That part focuses on evaluating the guideline development process and on tackling some of the challenges with implementation, dissemination, and surgery-specific barriers. And the academic output is great. Most fellows come out with several publications as both first author and co-author, plus lots of presentation opportunities and networking across multiple surgical disciplines in both Australia and back in the US.
And the other position is partial FTE role with SAGES Guidelines Committee. It doesn't require relocation and you can be fully remote. You'd be leading systematic reviews and helping expert panels build high-quality, evidence-based surgical guidelines. It's a great way to gain experience in guideline methodology, strengthen your CV, and build connections across multiple surgical disciplines and SAGES. In this role, you'll also come out with several publications, both systematic reviews and guidelines, where you'll contribute as a co-author and often as a first author.
Exactly. In summary, the Australian-based fellowship allows you to have an international experience and obtain a master's degree while also developing guidelines, while the US-based position allows you to remain local and take on other research opportunities should you choose. Both positions are fantastic opportunities for surgical residents that are planning on doing a 2-year research commitment.
Applications are available on the SAGES and RACS websites, and of course, feel free to reach out to us if you have any questions.
Thanks so much for listening, and we really hope some of you will apply.
Welcome to episode 33 of SAGES Stories, where we shine the light on some of SAGES' most impactful leaders. I'm your co-host, Dr. Kevin O'Hike, coming to you from Cleveland, Ohio.
And I'm Dr. Jenny Shao from Ann Arbor, Michigan. So today we are thrilled to welcome another SAGES giant, Dr. Adrian Park. Dr. Park is the Chief Surgical Officer and Clinical Innovation Officer at Meritus Health, a professor of surgery at Johns Hopkins University, and a globally recognized pioneer in minimally invasive surgery. He has a career that spanned decades, and he's been instrumental in advancing surgical education, innovation, ergonomics, and has served in many numerous leadership roles, including chair of surgery at Luminous Health, and is a key leader within SAGES itself. With over more than 200 peer-reviewed publications, dozens of patents, and a legacy of mentorship and international collaboration, Dr. Park's story is definitely one of relentless curiosity, passion, and dedication to improving patient care and surgeon well-being. Dr. Park, welcome to SAGES Stories.
Well, thank you so much, and thank you for those very kind words.
Absolutely. We always start these episodes with the guest telling us a little bit about themselves in their own words. And I think for your story, given how kind of interesting and maybe broken up, maybe let's start from your early years up until you finished college. So what were some of your most memorable events along the way, kind of leading up to the point where you eventually went into medicine? And then we'll hit on that next.
Okay. Well, I think probably one of the more interesting things about that first part of my kind of academic journey was that by the time I had finished high school, I think I'd been to 13 different schools. on one, two, three, four continents,
Oh boy.
in and out of different systems. So
Probably a couple times in a year at some point if you did 13 of them.
yeah, sometimes more than one a year. Yeah. And I mean, that's starting way from, kindergarten type thing. And then, so I spent many formative years growing up in East Africa. I was born in Southeast Asia to British parents, and so lived in Britain, England, and Ireland for a while. We, I guess, immigrated to Canada, and then from there went overseas again to Africa and East Africa, North Africa, Middle East, and so one of the things I didn't discover until I was in my early 40s, or just about 40, was that I knew I didn't belong anywhere. I knew that, and this crisis of identity really landed when I was a freshman in university, because at that time my parents were living in Africa. My sister was doing her school in England, and for not very good reasons, in the grand scheme of things, I decided to go back to Canada to do my higher ed. I could have as easily gone to England, so when you're in college, you meet 100 new people a week, and they basically say, "Hey, what's your name? Where you from?" And I just didn't know where I was from. And so for a long time, and again, people who know where they're from take it for granted. From my perspective, it's a really important thing to know where you're from and where's home. And so it wasn't until I was about 40 and I was speaking at a missionary conference in Thailand, and I met the woman who coined the phrase "third culture kid." And then she told me, "You're what's called a third culture kid, and that's your tribe, and that's where you belong." So a third culture kid is someone who's born to a culture to which they don't belong. I was born in Malaysia. I was not Malay. To parents from a culture to which you didn't belong. I was born to British parents and never been to Britain. So I belong to a third culture. And there are characteristics. There's a bunch of us back in the day. My day, it was because your dad worked for Shell Oil or was a diplomat or something. Military doesn't count because they move their culture wherever they go. And there's several notable TCKs, or third culture kids, of my vintage. Obama is one of them. Barack Obama is a classic TCK. So can be a cultural chameleon, usually facile with languages, can work a room, gravitate to all manner of different people's groups within a room very comfortably. So that's what I learned in my freshman. No, I didn't learn that till, again, I was about 40. That's where I was from and that's where I belonged. So my journey academically had been in and out of systems, in and out of countries, British system, American system, international system, Canadian system, all sorts.
Can I ask what your family did that moved you around so much? I was just kind of genuinely curious.
At this point, I'm wondering if my dad was just staying one step ahead of the law. I think that in reality, he had a very interesting career. He was an engineer and an educator. So he had consult for a while, and then he did a lot of development work, like really cool development work before it was a thing. And that kind of, I think, set part of, sowed the seed in me. But he would work for, the British government. He worked for the Canadian government. He worked for the Malay government. And so he was involved in the development of countries and infrastructure and stuff. And then he'd go teach college for a while, and then he'd go do different things. So again, he was either a step ahead, like could have been MI6 for a while, I don't know, or he just was what he said he was, an engineer and an educator.
Yeah, I mean, that sounds MI6 to me. I know Mission Impossible, the final one's coming out, and we have another close friend who kind of has a similar story. And I remember one time someone brought that up at a party, and they're like, "Hey, we want to introduce you to our friend. He's in MI6," and he literally like turned around and walked away. So we were like, "Oh boy, maybe that has a shred of truth to it." So, and I, of course, won't mention his name on the podcast to out him or anything like that. And I'm not sure he's one of the tens of people listening, but I would put your dad in that category with hearing that story, because those are really, really fascinating journeys and different cultures, radically different cultures.
Absolutely, absolutely.
Is there one in particular that you feel like had a big impact on you growing up, or one that you like always sort of remember or think about?
Well, Kenya were really formative years, and of course everything is set in time and nothing stays the same, and um, uh, so the time was really important. Like what was going on in Kenya at the time was really important. I then was in Algeria for a while, and Algeria is a very closed country. It's a North African country, and that was the most incredible experience. There's no tourists, there was no Western influence, at all. This is well past that won their independence from France, and it was a very closed country, and so it had its unique experiences. Because there was no tourist industry, there's so little development. And we're way off the path here, but
Not at
it was
all. This is the path. This is
okay.
the path.
Well,
It's the
so
story.
so it was a country that had huge presence during the Roman Empire, and it's just west of Tunis and Tunisia, and so there were Roman villages that were preserved up to almost 3 feet high on the just west of Algiers when we were there, and like there was amphora pottery, like this stuff was like nowhere else. Would you see stuff that wasn't preserved? It was just there. So, and the coast was absolutely pristine. It hadn't been spoiled. There wasn't development along the coast. So again, that snapshot in time, and no one spoke English. And as a young Western male, you were just wherever you go, people wanted to talk to you. And
How old were you then? What years was that?
I would have been 17. I was in and out, 17 through about 19 or so. So I was
Yeah,
older. We spoke English, so that's where I first learned French. I didn't really
that's where
learn
you
much
first.
Arabic, but and interesting, well, not to get either political or spiritual here, but I'd come from the West. I'd spent some time in the West and like in North America, and our Western culture, and we're all anybody cares in high school is who's going out with who, and you see what movie and this and that, and here I was in this very closed, kind of oppressed country, and if a group gathered around you to meet with you, first of all, you had to know that there's an informer somewhere in the group. It was a very much in the leftist sphere, very socialist to the left country. But the other thing is, young people wanted to ask you questions of substance because they had no access to Westerners. They wanted to ask you questions about capitalism versus socialism. They wanted to talk about Islam versus Christianity, Muhammad versus Christ. I mean, these were young people. Like in America, and back home, they just cared about what was playing on the movie theater. These people, because these young people, my peers, were faced with such issues about freedom and this and that. It was just remarkable. I'll never forget that experience. So all of these are kind of a little bit crystallized in time, but all very formative in different ways. And as a young person, having lived in all these places, you come back to North America and you've got all these great stories, and your friends want to know if you actually saw Tarzan, and it's like, no, he's not real. And did you see any tigers? And it's like, there aren't any tigers in Africa. And then they were on to the next thing. And so, it as a young person, it imbued a tremendous perspective, and something goes on in the world, and there may be somebody that I know and a friend that's affected by it. So you're unlike most, of my contemporaries. I actually cared what went on in the world at that stage of my life, and that's just continued to develop through my life.
Wow, I can definitely see how this probably ties into some of the later questions we're going to ask you. This is so interesting. I feel like you probably have a very different cultural perspective than some of the other people who probably didn't have the experiences that you did growing up, which is really, really awesome. I guess from there, how did you decide on surgery? Like how did you decide that you wanted to become a surgeon?
Yeah, so I am not one of your little, picket fence, knew from age 5 that I wanted to be a surgeon. And by the time I was in second year medical school, heading into third year almost, the only thing I knew I did not want to do was surgery, because pretty much every surgeon I was exposed to was a twit or a jerk, and I did not want to work with them or be like them. And I'm sounding flip, but it's true. I wasn't compelled, but I wanted to go back to Africa. I wanted to go back to the field. And I did know at that point how much they needed surgeons. And I had figured that you can learn a lot of stuff out of a textbook. You can learn, with all due respect to our internist colleagues and our pediatrician colleagues. I mean, you can learn a lot of that out of a textbook. You can't learn surgery out of a textbook. I knew I needed training for that. So, not because I had always wanted to be a surgeon, not because I felt like I was a member of the club. I was not in the club at all. And you're supposed to apply to a gazillion places. I applied to one place. And I applied to other types of residencies as well, non-surgical. And I got into surgery, and it was very competitive at the time, and I just was not happy at all. But I believe that's where I was supposed to be, and it took me several years to become a surgeon, to feel like I was in the club. So for anybody of the 10 who are listening who feel like they're not in the club, I might look like I'm the kind of guy who is in the club. I totally was not in the club. I never felt like I was in the club at all.
Honestly, I feel like at the end of the day, we're all kind of nerdy. I mean, like, let's be real, we're all doctors, we're all surgeons. We spent probably a lot of time reading books. I think all of us have in some way, shape, or form felt like we haven't been a part of the club. And I think maybe that's why all of us gravitate towards SAGES, right? Like we're meeting people who are very similar to us, who have similar interests, who care about the same things that we do, find the same things interesting. So yeah, I don't think you're alone in that one, but that's definitely really, really awesome.
Yeah, and you're not uh, the only guest who's had that same sentiment about surgeons, and we do actually have some med students who listen, and some patients, a couple patients of mine, and I think many of them, when I talk to them, or when they come up and talk to me afterwards, they often say, the stereotype of a surgeon really doesn't match a lot of what we've seen. And I think that thankfully that stereotype has changed, but I'm sure that it lasted, and certainly through the your era of training, which is a little bit before ours, not much more, but a little bit before.
Very
Um,
kind.
and I, of course, I know you, and I've worked with you, and so I have a little insight into one aspect of your career, and that's your commitment to global surgery. I think this is probably a good time to maybe ask about that work, especially through your work with organizations like PACS, your work in Africa. We've talked a little bit about that on the podcast before, with some of my trips. But what's been kind of one of the motivators for you to engage in global health, and specifically, how has that shaped your view of surgery as a profession and a calling, to patients globally?
Yeah, thanks. Just that last phrase you used, surgery is a calling on your life. I just gave a grad talk at a big Department of Surgery last weekend, and the title of my talk is "Surgery is a Calling." And one of the points I make is that regardless of your belief system or worldview, and don't kid yourself, all of us have them. I'm a Christian, and so that affects mine. Uh, we all have a worldview. And so the point I make is that regardless of your worldview, you kind of have to see surgery as a form of calling in your life. If you don't, the opportunities to be frustrated and even embittered are really more significant. And when you do see it as a form of calling on your life, then uh, it's a lot. I wouldn't say it's easier, but it's a lot easier to see it as a worthy occupation of your skills, talents, and abilities. than if you don't see it as a calling in your life. And so that time for me, I can point to when that happened for me, and I haven't looked back since then. But so I had thought I was going to go into surgery to head back to the developing world. That's why I got into surgery. And over the years, and how that ended up happening, and the route I went was, was not at all that I planned. Nothing that I planned. And I'm 3 steps ahead. Plan A and B and C. And so how that played out in my story I think it's interesting easily. And so the global surgery piece, I've basically been doing this for 25 years. It's now kind of a shiny, sexy thing. Global surgery is, and so that's good and bad. The bad is that it's shiny, and so everybody's. I'm not saying everybody. There are sometimes there are groups that want to do it, and there's this a lot of attention, and then nothing follows up, and there's no longitudinal relationship with wherever you're going. But the good is that it's bringing focus to an area that never had focus. So for most of the 25 years, if I'm heading over to wherever I'm heading, the only other people heading over are those involved in managing communicable diseases, the malaria, TB, and HIV folks. And for the rest of the Western world, surgery is a luxury, and we just can't be thinking about expanding that. So the fact that it has such that everybody's thinking and talking about it now is a good thing. I'll reserve judgment that there may be some misdirected initiatives coming out of it, but net this focus on global surgery that we talk about now is no more than 10 years old. And so before it was a thing, I had relationships, and I've known, having lived and grown up like in Kenya a long time ago, I was pretty fluent in Swahili, which is not much use over here, and I speak like
I was going to ask how many languages, given your journey. That's a quick hitter. How many languages do you?
So I speak French. I'm fluent in French and English, and I used to be pretty fluent in Swahili. When I'm over in Kenya for more than a week, 10 days, stuff starts to come back out of the archives. Just I don't even know where they're coming from. These words will come.
Isn't that amazing when you're back in an environment? It just start dreaming in it again.
Yeah. Now the problem is that in Kenya they've really picked up their game. The Tanzanians and the Ugandans particularly Tanzanians, are pretty snooty about their Swahili, and Kenya is getting a little bit more so. And I just speak what's called kitchen street Swahili, so I don't worry about tenses and conjugations. So I was I had these relationships, and I just got involved, and I very much believe in longitudinal in developing relationships, because trust only comes when you're showing that you're committed, and you're committed to relationships. And this isn't surgical tourism or photo op mission trips. This is, hey, I want to be here for the long run, and engage and invest and that kind of thing. So I had my first so I'll step back because I think this is instructive. So I trained in the era of surgery that anybody, I say this not infrequently, anybody of my vintage who speaks fondly of their residency years, I think is a sociopath, because those were just awful years. You had no life.
Truer words have been spoken.
Do you feel like we just block out the bad stuff though? Because you say it's kind of like childbirth. You just selectively forget the bad things. So
we wouldn't know about that, Jenny.
I don't
know. We'll take your word for it. I think childbirth is there's probably more of the pain.
No, but I don't know. I mean, yeah, okay. I want to hear this.
Well, it really was. This is well before any duty hours. This was, and it was not good. It was not good. And, marriages, failed at a ridiculous rate, and it wasn't good. And so here I am in a residency, and in my first year is fun because you're learning all the time, and you just have to stand in a room and you're learning something. Your PGY 2 year, you actually have to start reading. And then, we routinely had 100-hour weeks. I mean, that was a routine week for us. And it's hard to read and hard to do stuff, and more is expected of you. So as pretty miserable. I'm sharing very candidly here, but I was pretty miserable, and thinking, I don't know if this is really for me. I'm not in the club. I don't particularly enjoy this club. And I went to my program director. I was at McMaster University where I did my residency. I went to my program director, and there were no such things as electives. There's no such thing as global surgery. And I basically said to him, I wanted to go back to Kenya, but I didn't have any really active contacts in surgery at that time. But I basically said, I want to take time, and I want to head back to the developing world to do a surgery kind of elective, but there weren't any such things. I said, I want to take time off to do this. And he said, no, you can't, you'll get no credit for it. There's really no such thing. And I had determined that if he said no, I was going to quit. And, I had grown up in the developing world in what we now call LMICs, what we used to call the third world. But my wife had never been overseas, and I wanted to see if this is something that she could do if we were going to do this. And so I found this place. I won't get any sympathy when I tell you it was Fiji, because Fiji had just undergone a coup, and all of the doctors fled the country. And there was a guy, my professor, the chief of ped surgery, had a son who had just gone over there, who was a general surgeon, and had just gone over the Fiji Medical School and what's called Colonial War Memorial Hospital, the main hospital in the country. And he was like holding the fort on his own. So I went over, having done my PGY3 year, pretty much, and I was probably about the 5th best trained surgeon in the entire country at that time. So anyway, went over to Fiji, and again, Jen had never been in the developing world. I was back home. I'd never been to Fiji before, but I knew this, what it was like. And we were very involved with the local community. We were very involved with a local church community there, and just with Fijian community, spent very little time with Westerners there. And we did everything in this hospital. We did everything. And I was what's called a senior registrar. And when I was on, it was it. I was it. And you did everything independently. You did not call your faculty for anything. And this was a huge shock, but man, you had to learn quickly. And life
how long did you stay there?
It was only about 4 or 5 months, but
only about 4 or 5 months. That's a good portion of your training.
Yeah.
Wow.
Yeah.
I can tell you, if there, I'm sure there are going to be trainees listening. I mean, this is a huge desire these days, as you kind of alluded to. That's a great amount of time, actually. It
was a quarter. It was about a third to a quarter of the year.
Wow.
It was a good chunk. And, he told me I was going to have to make up all the time. But what happened in Fiji, several things happened in Fiji. I could tell you so many stories about that. But the main thing that happened in Fiji is I became a surgeon. And I realized in Fiji that that's where I was supposed to be. Wow. And I had been kicking and screaming this whole time. And we did everything. And again, life was cheap. I could tell you so many stories. But I became a surgeon in Fiji. And when I came back, and Jen, to her great credit, adjusted and said, I can do this. If you want, I can do this. And so we had to go back. And
where was she from?
I go back,
Canada?
She's from Canada, yeah.
Okay.
And she had, me and my 13 schools, she had been born into a house, elementary, middle, high school, college, married out of a house. And I couldn't even tell you how many houses I'd been in by the time.
You're like, I was in a house for about 30 seconds and then
yeah. So the thing is, I go back to the ending the PGY3 year, starting the PGY4 year, and I had a spring in my step. I knew that I was with totally burned out and depressed, colleague residents. And man, I had a spring in my step, and I've never lost that spring. And that was, I hope you guys were born then. That was in 1989. You guys should.
Oh yeah, born. I was.
Yeah,
I was 10 years old. So. I was 10.
Okay.
But that's great. So you found your calling in Fiji. And I mean, is that sort of where your interest in MIS began? Or did you have any other mentors around this time that got you really interested in minimally invasive surgery? Like what kind of experiences sort of set you down this path?
So there were no mentors, and that's why I've kind of overcompensated most of my career investing in mentoring. There were precious few mentors available. So I went back and I said, okay, this is what I'm supposed to do. I'm supposed to, be heading back to the developing world, and we knew what we were going to do. Found an opportunity, tapered the rest of my career, my training to that. So there weren't anywhere close to the fellowships there are now, but tailored the rest of my training to going to the constrained resource type place. And at the halfway through my chief year, the wheels fell off that opportunity, and not at my end. So we knew where we were going. I didn't line up anything else, didn't line up any fellow, didn't look for any jobs. This is what we were doing. The wheels fell off this, and we were pretty shocked and pretty upset. And I had no idea down through the final 6 months of my chief year what I was doing next. And I went to a board review course, and again, these were in their infancy at the time. And this guy was spouting heresy about what you could do through small incisions. Like you could take, gall bags out and do other things through small incisions. And this is utter heresy. And it's like, but I was captivated by this idea. So I had nothing lined up. And so I went and talked to this guy after this presentation. And I said, hey, can I spend time with you? There weren't really fellowships at the time, but that was Michel Gagne. He was early in his career. And so I went and worked with
Heard
Gagne.
of him. Yeah, I heard a thing or two about him.
Yeah. So I went and worked with him, and this was still early enough, and Al Pomp as well. And
Al Pomp, okay.
That was early years. And, I had a proclivity for this. We did a lot of stuff together. We did a bunch of world firsts together. And so I come out of this year having never really thought of academic surgery, never thought of it, didn't have any pedigree, didn't have any pedigree or anything like that. And here I am on the cutting edge of technology. And all of a sudden, I had a very inquiring mind. I was a creative thinker, and I had a technical, proclivity and gifting to do this. And so we just invented all this stuff. So all of a sudden it couldn't be a more different path than what I thought I was going to be. I ended up, kind of being in demand. We wrote a bunch, we talked a bunch, and then things went down that road. And then I, pursued this. I got thrust into, if you would, this academic career, although most of it in the day when it started out did not start out in the academic world. It started out in the community, and there were only a few little academic places. And so those of us in the pioneer years, there were very few in academic places. And so we were kind of in demand, early on. But that's not what I planned at all. Again, didn't pursue the right, through my residency, and I didn't publish a ton of stuff through my residency. I didn't feel like I ever had the pedigree or the tickets or whatever. But that's how that happened. And then I had what I call my 30,000 foot epiphany. At one point, I was like early in my career. I was flying all over the world, speaking on this stuff, demonstrating surgery. Usually, again, back in the day, you had to be put in at least 10 years into your field before anybody's going to listen to you say anything. And I was this young guy, and there were a bunch of us at that time, that the first kind of cohort, if you would, of the pioneers. I was the youngest of them. And I had this, I was flying to the Middle East, to the Far East somewhere. And I was thinking, wow, you're, anyway, I won't go into that epiphany, but I realized I wasn't where I was ever planning to be. I had not done what I thought, and I thought there, as a Christian, I thought there might have been a divine hand in where I was, because I sure hadn't done the work to plan it or anything. And so I thought, so what am I to do with this? And one of the roles I've been able to have, whether or not we have time to talk about it, is kind of trying to introduce MIS to the developing world, because I thought that's where I was going to be. I thought I was going to be in the third world, in the LMICs. And I was, in fact, I was in the ivory towers, which I had never planned.
Wow. That's fascinating. I think this next question builds off that, in that when you see kind of the work that subsequently developed, not only was it speaking and writing, but also inventing. And you touched on that. You have numerous patents. You've been on the forefront of development of many new surgical devices and techniques. Where did that passion for innovation in surgery come from? And maybe you can share a story about one of the most, your favorite inventions or one of the most impactful things that you brought to the field.
Well, I think that when this heresy crossed the pond, when these crazy ideas came across the Atlantic, I think the majority of people thought it was heresy and dangerous and to be avoided. And I think for a few of us, it captured our imaginations. And I've been thinking for a long time that the advent of laparoscopy is going to be judged by history on par with the advent of anesthesia or antisepsis in terms of how radically it altered the care of the surgical patient. But at the same time, it's amazing how little historians and social scientists how little attention they have paid to this. And so, yes, we started doing things through small incisions, but you have to also appreciate that at that stage, up to the late 80s, general surgery was a pretty stagnant field. We were losing more procedures than we were gaining to adjuvant therapies and endoscopic stuff. And ERCP had just started, so we're losing a ton of biliary tree stuff. And so when MIS kind of came along, for those of us with whom it resonated and they captured our imaginations early on, I believe that it unleashed these pent-up creative surgical juices and led to an era of creative surgical thinking, unlike we may have known in surgery. And so yes, we were thinking of new techniques, but the laparoscope had nothing to do with the fact that we were, challenging dogma. Why do we need an NG for this? Why are we putting a drain in there? Why are we doing this? So we started challenging all manner of surgical dogma, not just because of the laparoscope, but because I believe this unleashed this creative surgical thinking. And so this was prime for me because I've always been pretty creative and imaginative and, I think an original thinker. And so this was, like the button down conformity of surgery back in the day when I didn't feel part of the club, I was never going to be part of that club. But here was this new thing that we could just think differently, and not just about, holes in this, but about anatomic approaches, about physiology, about quickly moving into endoluminal stuff. I mean, in 93, I got to tell you, Gagne and I, this was my work. He'd send me up. We were working on dogs and stuff. We'd operating during the day and then up to the lab every afternoon. And I was taking down internal mammaries with no energy devices other than cautery, had clips, but no staples, no anything. And we were taking these down to sew on a beating heart. We were thinking back in 93 about, cardiac stuff. This was stuff that Michelle was really driving this. So, I mean, we were doing crazy stuff early on. And notes came along looking at other endoluminal ways, to access pathology. We were thinking about from the get-go. And so again, this captured my imagination. I was primed and ripe for it. I again had, I think, some skills and abilities that were a good match, and kind of we took off from there.
Wow, that's really, I mean, I'm just still so amazed that you have so many different patents and all of these things that you've been able to build. And I really resonate with what you said about being a creative, because I feel like first and foremost, I always see myself as an artist. And that's one of the things that I love about surgery as well and so I do a lot of complex hernia surgery now. And one of the things is I think it really is the perfect intersection between, the science of medicine, but also the art of medicine, where you can really make something beautiful or functional or creative. And I think that's one of the things I really love about it. And I think with your forward thinking and all the things that you've done, what are some things that you feel like are going to be critically important in surgery in the future? I feel like there's so much talk now of AI, integrating new technologies. I just kind of want to hear your take on that. What are some of your perspectives about everything else that's going on in the world in terms of technology, robotics? Just kind of curious to hear your perspective.
Yeah, thanks for that question. You just touched on this. I feel so strongly about this. We are so privileged as surgeons because there is so much art. There is so much science that we do. But if the art's ever removed, man, I'm checking out. Now, again, that's big talk, but I mean, it's like, it's such a privilege that
Yeah.
that we are able to engage your artistic brains and our creative brains at the same time. So one of the things I'm quite concerned about is critical thinking and original thinking, and I think that I'm always going to write stuff. I'm always going to write, and I'm going to write what comes out of my brain onto the paper or onto the thing. And if I'm going to check anything, it'll only be well after the fact that I'm going to say, am I missing anything here? Like my buddy Chat GPT or something. But the first thing is I'm sitting down and it's coming out of my brain. One of the things that's going to happen is, I mean, there's a lot of knowledge out there, but I think that there will always be a market and always be a need for original thinkers, because original thinkers, create to the body, contribute to the extant body of knowledge. And what happens if that body of knowledge is not contributed to, then AI becomes pretty flat. And everybody's just asking different questions, that interrogates a set knowledge base. So I think that original thinkers and critical thinkers will be more important than ever going forward, and we'll always have a job. I think that if you're using AI to augment, the solid core of critical thinking and original thought you've already brought to whatever issue it is, I think that's fine. I think when you step back and abdicate, that good work and that important work, then we're in trouble. And and I know, like one of the things, for instance, that that I think about a lot is, I'm obviously, I think one of my advantages in life around technology is I never fall in love with technology. I'm not a technophile. I don't fall in love with technology for the sake of it. I love clever ideas, and I celebrate simplicity in design and originality. But I never fall in love with technology. I move from one to the next and see how it can be harnessed. And so, for instance, with the robot, I think we've checked a lot of our critical thinking at the door. We will often spend more time thinking about a suture or thinking about a mesh or whatever than we will about, hey, should I use the robot for this or not? What's the indication for using the robot? What's the evidence for using the robot? And I won't get down that trail because I don't know. I know you guys use it. And again, when there's a place for it, I'll use it. But I think just even critical thinking around that. So that's one of my great fields is we need to train folks with a sense of history, with a sense of who's kind of, what works contributed to where they've come to. I'm amazed when I give grand rounds or I'm a visiting professor, I'll talk to residents and even sometimes to junior faculty. I was at some place recently and I was just telling a story and I put out a name, Blank Stairs. And this is a name you guys will know. And then I ran through several names and Blank Stairs. And I'm thinking, really? You don't know these people and what they've contributed?
But here's what I might push back a little on that, because even our own patients, like I would ask someone, they may have been operated on someone famous and, it was decades ago. And, and I'm like, who is your surgeon? Like, I don't know. I think it's okay for us to not I get it. I think history is important, but it's also like, I think sometimes surgeons want it to be, so elevated that they would name things after themselves. And I don't know. I'm okay with sort of like, we play a role, we try to help people, but we don't necessarily have to be elevated to a point where we're occupying space in people's brains either.
Yeah, I think I'll push back on your pushback. I'll raise your pushback with a pushback. So absolutely, this is not about hubris. This is about acknowledgement and crediting, those, work that's gone before they built on. I hear stuff, you hear stuff, presented all the time as though it's original stuff. And it's like, actually, so-and-so published on that in whatever year. And, and so it's not venerating anyone for the sake of veneration. It's kind of, understanding a little bit how you got here. And like one of the images I had forever, and patients who can't remember their surgeons, it's like, buddy, you put your, we all get them, but
they never remember their surgeon.
It's true, they never do.
Remember their surgeon. They could have been operated on, like I'm sure Jenny has had people that were operated on by these huge giants in Michigan, and the patient's like, I don't know, it was some guy who came in and did my gastrectomy. And you're like,
that's
your gastrectomy, they took out your stomach. You don't remember who it was. They don't remember. They don't. Ultimately, it's okay. I got to the point where I'm like, I'm okay with that.
Yeah, it's it's an interesting phenomenon. I'd say the minority of my, and it's not because they have to know if it's a fancy surgeon. It's not like, this was, you put your hands and your life in this, and you can't remember whose hands. But anyway, it's a not uncommon phenomenon. But the thing that I'm talking about is like part of the thing is I had this image for many years, early on, is like, we're kind of head down, bushwhacking through jungle, and then you look back and there's like this paved road behind you that people are kind of sauntering down. And it's not like they've got to, again, venerate anybody who's bushwhacking, but just understand that somebody was there, somebody paved that road, and there was work that you built on that allowed you to do stuff. Especially, like, I think it's a different thing. What I'm saying is a different thing than a patient not knowing their surgeon. I think.
No, I know, and I agree. A healthy dose of respect for the past is needed, but I think the past sometimes wants to be maybe closer to venerated than they need to be. I think surgery is moving forward. The way we do things continues to evolve, and there are maybe not necessarily clinical benefits shown in the poor quality data that people put out, which is the vast majority of surgery. It's like level 3 and below data. Even when you look back at all the people surgeons were surgeries were named after. But I think it's okay for us to also, respect the way future is moving in surgery too.
Yeah, and maybe I'll have the final say on this, so you guys stop when up being.
You're frozen, Jenny.
We lost you, Jenny. Just as she was, the world knew that she was going to. So I will jump in until Jenny comes back, and we'll let her do hers. And I know she has a follow up, but I wanted to actually pivot toward one of your other loves and passions, which is surgical ergonomics. And I think that's a topic that's often overlooked. Actually, there was a fantastic session on it at SAGES last year. What prompted your focus in surgical ergonomics, and what have you learned about keeping surgeons safe and well in the operating room?
Yeah, it came out of a fairly a sense of self-preservation, the need for self-preservation. So, early on, there was it was just very clear early on, there was no going back, that patients were voting with their feet, that some of the differences were so profound. There were so many studies that were never done. I was a part of so many study groups that were never done, because you could never recruit patients to the possibility of randomization to the open arm of adrenalectomy or open spleen or whatever. And so those studies were never done. So patients were already voting with their feet. And they were doing so well. And so no going back for us. And so we were standing on our heads back in the day. We were like standing on our heads to get these operations done. We hadn't figured out, port placement and that kind of stuff. It took a while. There was no articulation of anything. There was, we were just standing on our heads. And so, and we didn't understand a lot of stuff. We were in these static positions with arms abducted, so much time with wrists flexed and ulnar deviated, all the worst things that you can do just to do these surgeries, because the patients did so well. And I remember thinking early on, I'm an active guy and I stay in shape, and I'm young, and this is just killing me. And then at a fairly early age, I ended up having to get both wrists operated on. And it was because of,
Wow. Really? What
so
age?
yeah.
That's when was that?
Um,
Wow.
I might have been late 30s, early 40s, something like that.
Wow. Yikes.
So it was that then
Mm.
made me say, okay, none of us are looking at this. I'm not an engineer, and the field was very young. But when I was at University of Kentucky, I connected with the Department of Biomedical Engineering, and we basically started these ergonomics programs. And I did one of the fun things I did, and this was 25 years ago more. I did in the early days of motion capture, one of the very first motion capture studies we did with the industrial ergonomics department. And I had the baubles on back in the day, and we did all this stuff. And I did a couple of lap choles. And by that point, I was pretty slick at a lap chole. It might have taken me, 15, 20 minutes. And I had all the comfortable carrying angles, and I was really comfortable doing this operation. And when I got the assessment back from the big professor, a couple of weeks later, it was very labor intensive research. When I got the assessment back a couple of weeks later, he said, if you were a small business, we would shut you down. It's like, what? That's a lap chole. You haven't seen me do a fundo. You haven't seen me do an adrenal. You haven't seen me do any of these other things. And so the operation that took the least time, that we were most comfortable at, violated all manner of industrial ergonomic risk factors. So that's when I realized we got a problem. We've got to organize study around this. And plus, I want to do this for a long time. Oh, you've been hacked by Ohio State, have you?
Yeah, so Jenny's back. The Ohio State University clearly hacked her. They don't really like the that school up there, as we say here in Ohio. So yeah, the Ohio State hackers. That's
Yeah,
right.
get it right. They might come after you next, Kevin, if you get their name wrong.
I know. All right, so you get the last laugh on that last bit, Jenny, and then we'll move on. But I did get to kind of hear about his ergonomics journey, and it's really a great initiative, and clearly we're laparoscopy brought on, and robotics will as well. I actually herniated a disc in my back after doing a lot of robotic surgery. So it's not so much the position is what I learned. And I think maybe we'll have Ed Young on at one point to talk a little bit about his prior engineering background on this, but it's really just the staying in one place for extended periods without micro breaks, I think, was the kind of key message I got. So even when I'm in robotics, I try to get up every half hour, 45 minutes, just stand up and walk a little bit.
Yeah, I think it really just has to do with that repetitive motion, right? So anything that's a repetitive motion can cause injury. It doesn't matter if you're lap, robotic, or open. So I think there's still so much to learn. And it's definitely a growing field. So it's really interesting. I think Dr. Park actually wrote that. I think you have this like really famous article / quote, like transferring the pain from the patient to the surgeon. So I feel like that was super clever and definitely an
And I
article
stole that. I stole that and said, laparoscopy is transferring the pain from the patient to the surgeon. And I said, robotics is transferring the pain from the surgeon to the robot. I did bring that up. I built off of yours, and I know you'll have a couple comments about
that. Actually true though?
No, it's, I mean, in a way, like let's be honest. The era of laparoscopy developed when the average BMI of a human in the United States was in the 20s, right? In the 80s and 90s. The average BMI is now in the high 30s. So laparoscopy in a high BMI patients is very hard for a surgeon. You do transfer that kind of torque and everything to the robot when you go to the robot.
I see what you're saying. Okay. I'm picking up what you're putting down now.
Okay, perfect.
I was like confused for a second.
Yeah, so that like when you're up there and you're BMI 70 gallbladder is not the gallbladder of 1989. It's just not, right? That was just not a gallbladder in 1989.
Yeah. Actually that's really interesting. So one of the abstracts that we recently sort of worked on in our group really kind of talks about that as sort of the rise of robotic cholecystectomy in this day and age, and about its utilization and specifically morbidly obese or higher BMI patients, which I think is kind of really interesting. So I don't know. I'm not sure we want to get too into the weeds about robotics versus
No, maybe
laparoscopy.
we'll
That's
leave that
probably
one.
going to be a crazy topic altogether. So maybe I'll pivot one more time and talk, a little bit about surgical education. So Dr. Park, I was kind of surprised to hear you say you didn't have any mentors like early on. So I guess that's kind of interesting to me, but I know you've mentored like so many countless fellows, residents, and colleagues. You actually probably don't remember this, but I actually interviewed at your MIS fellowship when I was a resident. So kind of just want to talk to you a little bit about, qualities of a good surgical leader and mentor. How can we continue to foster the next generation of innovators and compassionate surgeons?
Yeah, these are all good questions, you guys. So one of the things, like whenever I'm recruiting anybody, I've recruited anybody over all the years, I always talk about the 3 C's. I look for, and the order varies, but usually the first one's always character, competence, and chemistry. So that's what I always look for, the kind of 3 C's. But the thing that I say that I wish there was a serum marker for it, or there's some way to bottle it, identify it, is that what I really look for, and the people who make their mark are not the people who can jump the highest or run the fastest or lift the most weight or be the most beautiful or the smartest. The people who leave their mark in our field are the finishers. People who say what they're going to do and then they do it, and usually commit it to writing. But there's lots, any college meeting you go to, any SAGES meeting when you're in the lobby or having a coffee or at the bar, there's so much hot air that's usually being expounded all over the place. And it is the finishers who leave their mark. And, there's another thing that I've thought about recently. We said earlier at the start of this thing that regardless of your worldview, I think if you don't see surgery as some form of a calling versus just a job, I think you're gonna have a more difficult and potentially fraught career, because there are such unique stresses and challenges with this calling. But again, if you do see it that way, like I have not looked back ever since Fiji and thought for a second about the best occupation of my skills, talents, and abilities, and it's as a surgeon. And I have a doubt of 1,000,001 other things about me in my life, but that one I don't. And so if you see it as a calling, I've also felt strongly that no matter where you go, whether it's academe, private, group practice, urban, rural, whatever, if you're in this profession, if you've responded to this calling, I've long felt, and I'm old enough that I can opine a little bit, I can spout off philosophically, but I feel that if you responded to this calling, wherever you end up, you have a duty to posterity to leave this field better than you found it. It's not just a job you're checking in and out of. You have a duty to leave this field in a better place than you found it. And so some of us will write. We all should have a spirit of inquiry. Some will discover, some will invent, some will describe new techniques and the like. And in some ways, those are all really important. Those are all really important ways for our field to advance and for you to contribute. But in some ways, all of those have a shelf life. I've written some pretty seminal papers, and every time something in that field was written, I'd be checking, did they reference me? And they reference me, until they stop referencing me. And everything, it always happens. You stop being cited at some point. Every patent that you have allowed, every patent that you have issued has a shelf life. Everything, with the rarest of exceptions, our legacy will never be what we write, invent, describe, or discover. With the rarest of exceptions, our legacy will always be in one area. And that is, no matter where you are placed, your legacy will always be your investment in people. There's no shelf life to your investment in people. And so that's part to my view of the calling, is, if you're a resident, if you're a fellow, if you're a junior attending, if you're a senior, there are always people around you into whom you can pour yourself and into whom you can invest. And there's no shelf life on that. And your impact on those individuals, there's no shelf life on and how that, whatever you might influence them, how that gets processed and passed along. So I know what I'm saying sounds a little bit pithy, but I believe it to the core. I believe what I've just told you to the core. These things that we need to do, our duty to posterity, but your legacy will be people. Your legacy will be what you have poured into other people. The end.
I mean, I think that's gold, Adrian. I love that. I believe that as well. You may or may not have heard of Brent Matthews' theme for SAGES 2025 is actually falls really in line with that, which is connective purpose. And he's been encouraging people to share stories about, not necessarily how they got involved in SAGES, but certainly as the official podcast of SAGES, we focus on that. And his podcast just dropped this week. So if you have a chance, I think it was a good one. I'm biased, but you've been involved with SAGES from very early on in your career and served in many capacities: program chair, board of governors, leading committees, education, innovation. We heard about all of that. So if you were to kind of just drill it down to how SAGES has shaped your career and what you see as the society's most important contributions to surgery, maybe as we kind of get close to our end, we'll have maybe one more question after that. But how has SAGES shaped your career, and what do you see as the society's most important contributions to surgery?
Well, two separate questions. It for me was this place. The first time I presented was in '94, and it was this place. It wasn't big, small group, but just this creative spirit, and we could share these ideas. I was a really young guy, but you were already getting a lot of resistance in mainstream and in your hospital and this and that. And you could come to this place where people were so accepting and they wanted to hear your ideas. They'd kick them around, but they would listen to them. And it just, again, it fostered this, creative surgical thinking that I was talking about, this unleashing. It was a place where we gathered to do that. There was no other place to gather for that. So so it was this gathering place with real kind of rebels, pioneers, creative thinkers. It didn't take itself super seriously. It wasn't self-important. It was this place you came to share ideas, and that was such a powerful thing. That was such an incredible stimulant. And then it went on to get more serious, and so its contributions are legion. It'd be hard to identify any, but there's so many. Of course, FLS and the Fundamentals series, have really changed things. We can argue, what lifespan those things might have, or what, but oh man, that's a hard one, Kevin, to say one thing. I mean, there's so many. So what we did after the early years, we started to be a little more disciplined and structured about harnessing these wonderfully creative thoughts and organizing them into useful, not so much guidelines, but just, I mean, we were kind of the rebel organization for the longest time. The fancy dancy establishment, didn't want much to do with us, and it took a while to get into have any kind of a voice in the house of surgery.
We did hear a lot about that from some of the early episodes, some of the Ponsky era and Mercy and Marks and that crew. So yeah, we definitely, I think those.
But it was, but we brought credibility to this stuff. This stuff that was poo-pooed, you couldn't get on any other, agendas or any other abstracts. That we brought good science. We brought rigorous examination of the data. And, we weren't just a bunch of folks preaching to each other. I mean, we held each other to account. But man, you could have this wonderful exchange of ideas, and there wasn't this stuffy this stuffy sense of self-importance that the other things have, the other, ones have.
That's awesome. And I think definitely that spirit is still alive today, which is why I think so many of us really gravitate towards SAGES. So as we close for our last question, we have a tradition on SAGES stories that we call the We Are the SAGES segment.
We are the world. We are the world. We are the SAGES. We are the SAGES. Sing it, everybody. We are the ones who make it bright our days. So let's start treating. Have you had a good time tonight? There's a choice we make. We got a lot more coming. We are dancing.
So looking back on your long and distinguished involvement in SAGES, what is your most memorable SAGES moment? So it could be a meeting, a patient, breakthrough, personal connection, anything that really captures what SAGES means to you.
Ooh, that's a toughie too. That's a toughie.
I know we're full of toughies today.
I've had a couple of awards from SAGES that are just so deeply meaningful and honoring. I think, when I put on the program,
what year was that?
It was like a long time ago. It was in Philly.
Okay.
It was a long time ago. And I just remember how much work that was. That was before you had two program directors. In fact, I will lay claim to the two program directors.
Oh,
because
you were like, this is too much.
I appointed Danny Scott. I called him the tech czar. So I appointed Danny Scott. I got approval for the board to say, I need somebody to be chasing all this stuff for the exhibit hall and this, that, and the other thing. So after that, a year or so after that, they appointed two people. It was getting so big at that time that, Danny just chased all that. Like he was my co-guy. So, at the end of that, for me, that's very personal though, because so much work into that. And I remember, walking the hall at the very end with Sally, there's a few of us that hung around to the very end, things getting dismantled. And I'll never forget the sense of satisfaction, just like, this is my family. And just colleagues, and you guys already have it, no question, that you meet and friendships that you make that will run through your whole lives. And this is the richness of the life and kind of more of the academic side of surgery or being involved in this. These relationships are so rich and they will run through your life. And I could name so many names to whom that applies for me. So, so many moments of learning things at SAGES, of course, but the personal things. I had a couple of awards that were deeply meaningful to me. And, I'd leave it with that, and just the richness of relationship. Heck, I knew Jason just when he was like weaned. He'd just been weaned when I first saw him. And he was in some some monitor at that point. I think he had facial hair at that point too.
Well, Adrian, I can't think of a better ending point. Really want to thank you. Great story. I look forward to more time together, seeing you again in future meetings, and have a blessed night.
Yeah. Thank you guys both. All three of you. It was really a privilege and a pleasure to do this. So thank you.
Thank you for being here. This is awesome.
Thanks. Good night.
And that wraps up today's episode of SAGES Stories. You can view the show notes for any links to sites we referenced today. Visit sages.org for membership information and for the most recent news from our society. Follow us on Twitter at @sages_updates. Make sure you hit the like button and subscribe so you don't miss any future episodes. See you again next time, and remember, you can't spell minimally invasive surgery without SAGES.